So today was a day of highs and lows. I went to the presidential symposium, the opening ceremony, and I was quite surprised at how realistic a view we were given of what the future of personalised medicine could hold for us. And indeed, it was a little bit scary. It's not going to be straightforward. There are many, many roads that could lead us up the garden path, and we will put in a lot of energy before we come out with really targeted therapies. As before, we always knew these treatments would only be useful for a small percentage of patients, and that was really brought home to me. I then went to the lung session, and indeed it was quite cheery because some of the treatments that we've been using, we've been desperately trying to find good biomarkers that would help us use these treatments more specifically for groups of patients. And the first one is cetuximab. Cetuximab now seems to be giving good results if we choose the right patients on the basis of immunohistochemistry. And they've developed a H-score, which should be widely available in all our laboratories. And I think for the use of that drug, that will help. Bevacizumab had lots more data on it, and indeed, I think maybe in the UK, we haven't paid enough attention to this drug. There was very interesting results on the use of bevacizumab with pemetrexate and cisplatin, giving median survival figures of 15 months, which is really a figure we've never seen before. And I do think we have to be positive now because it looks like for some patients with lung cancer, we could begin to think of them as having a chronic disease and really living many years with these treatments. The other drug that was presented was sorafenib, and a little trial was presented from the Netherlands, really choosing the patients on the basis of RAS mutations. And I guess we always wanted the results of this study because we thought perhaps this is how sorafenib will work. But disappointingly, it didn't seem to select the patients who got any benefit from it. So sorafenib is a drug that has activity, but we don't seem to be able to have any biomarker that selects the patients. There was two other presentations that just updated some of the information we already had. The first one was a phase 2 study with afatinib, and we know afatinib's an active drug in patients with an EGFR mutation. I think what we didn't know is patients without a mutation also have a little bit of activity. In other words, maybe afatinib is beginning to look a bit like Tarceva, but nevertheless, it's good to have that option. And the final piece of information that we didn't have before was on the first PARP inhibitor that's reporting now in lung cancer. And I think the PARP inhibitors, there was a lot of enthusiasm for them at the beginning and a lot of interest because of perhaps them having a very specific mechanism. We now think that they're maybe not as specific as we thought, and in fact this is the first trial reported in lung cancer, and it was a negative trial. But there will be some more biomarkers reported and more science reported around that, and that's all good. So it was nice to get the new information on some of our old treatments and try and place them more specifically in patient groups so that we can find the groups of patients that really will get a benefit from them.
I had an excellent first day at the conference, and one of the studies that really interested me was the vismodegib study in basal cell carcinoma, which is a pivotal study and was awarded the best abstract. And it's a novel compound which is in trials, and it is a hedgehog pathway inhibitor. And hedgehog pathway, you may ask, is a very important pathway in embryos, both in humans and in fruit fly. And the reason why it's called the hedgehog pathway is that if it signals abnormally in fruit fly embryos, the larvae become short, stubby and hairy and look like hedgehogs. And abnormal signalling in the hedgehog pathway is implicated in over 90% of basal cell carcinomas in humans. So basal cell carcinoma, most common cancer in the US, Europe and Australia, most common skin cancer. However, it's normally surgically dealt with, and it doesn't progress to what they looked at in this study, which was metastatic and locally advanced basal cell carcinoma. And locally advanced means you can't cut it out because it'd be too disfiguring or cause issues. So in the study, it was a phase 2 non-randomized study, 104 patients, a third of them had metastatic basal cell carcinoma, and they all got vismodegib at 150 milligrams once a day, which they took until they either progressed or got toxicities. And what they were looking for in the study was an objective overall response rate of greater than 10% for metastatic basal cell carcinoma and more than 20% for locally advanced. And the results were astonishing. Lots of people had stable disease, but the ones that responded with metastatic basal cell carcinoma was 30%, and in locally advanced it was 43%. And the pictures were dramatic that they showed at the conference, which is why I found it really interesting. Toxicity profiles, not too bad. Greater than 30% of people had taste disturbances, alopecia, muscle pains in the short term, but in the long term, tolerance was a bit of an issue, with about 25% of subjects on the study self-terminating, saying they didn't want to take it anymore. So the impact, I think, to UK practice for this drug is quite low, because metastatic basal cell carcinoma only makes up 0.5% of basal cell carcinomas. So it's going to be a rare condition and a drug that we'll use rarely, and therefore it has funding issues attached to it. For a company to make its money back, it's going to have to be marketed in a certain way and priced in a certain way, so we're all going to be making funding decisions locally. And with regards to place in therapy, for those few people who do have metastatic or locally advanced basal cell carcinoma, it's amazing to have a drug that you can take. Maybe, as they did in the phase 2 trial, people taking it until progression or toxicity isn't the best approach. And for people with locally advanced basal cell carcinoma, perhaps we should be giving it to them as in a neoadjuvant setting prior to surgery, so then we can cut out once it's shrunk down. And for people with metastatic basal cell carcinoma, perhaps small bursts of treatment and then stopping for them so they can then take it again. But unanswered questions remain as to whether you get any resistance if you stay on the drug, or whether you get rebound when you stop taking it. But what was really interesting in the study was that patients who responded, over 50% of those had no basal cell carcinoma on biopsy if they responded, which was absolutely excellent. So in summary, very exciting data, the pictures were dramatic, and that's why it was the highlight of my first day at ESMO.